What's up guys, how are you doing? Welcome to our channel MRCP Made Super Easy. First of all, a big thank you to each and every single person who has joined our group and who has been watching our videos. A few of them are writing back to me really encouraging words which makes me want to continue this as long as I can and help as many people as I possibly can. Right, so today we are covering a very important topic. Now, not just from the exam point of view, but also from a clinician's angle. Because no matter where you are, whether you're sitting in the clinic, you're sitting in the emergency department, you're working as a resident, now this is one emergency which you cannot miss, and you should be thorough with this because you can actually save lives, and that's going to feel a lot better and help you sleep better at night because you're going to save someone's life, you're going to send them back to their family. So that's a big thing, and that's the most satisfying feeling for a doctor. Right, so today's topic is also important because NICE guidelines, they introduced an updated guidelines for management of anaphylactic shock in May 2021. Now I have also included the necessary changes that were made in the latest guidelines and the difference between the previous guideline and this guideline, so you get a rough idea as to what exactly changed in this guideline. Right, so we'll go into that in a systemic manner. So without further delay, let's start today's topic. Right, now the word anaphylaxis or anaphylactic, now it comes from a Greek word which means against for ana, and phylactic means protection, right? But it's actually contradictory to its meaning, because you mean against or it says protection. Well, what happens here is instead of protection, the body starts bombarding your systems and it can fatally kill you. It can send you into an overdrive, it can shut all your organs down, and it can actually kill you. So that's what happens over here, right? So this is an important thing. Now anaphylactic shock is IgE mediated, EEE. So it is a IgE mediated reactions are type 1 hypersensitivity reactions. So you got to remember that. And look at this person over here, poor chap, look at him, he has had an anaphylactic, he has had an episode of anaphylaxis from various reasons which we will be looking at in just a little while. And look at this poor chap, all rashes over him, look at his lips, he's developing edema over here, and he looks toxic, maybe possibly having difficulty in breathing, right? So let's try to help this poor man out over here, right? Now, as I said, contradictory to its name, it attacks your immune system reacting to something. What is that something? We are going to look at it, right? So we'll try to help these two people, right? And we will be able to help them only when we know how to manage it, right? So let's look at the definition. Now WHO has put forward a very important definition. It says serious, be scared of this disease, anaphylaxis, scared, serious, multiple systems. So they said systemic. We already know it is a hypersensitivity reaction, so put in hypersensitivity over there. Then it is something that develops rapidly. It's not like something that is happening over a period of time. So rapid in onset and can cause death, right? So according to WHO, anaphylaxis or anaphylactic shock is anything that is serious, has to involve multiple systems. It should be a type of hypersensitivity reaction. It should be rapid in onset, and it can cause death. Remember that, do not forget, keep saying that to yourself whenever you're free. Serious systemic hypersensitivity reaction, rapid in onset, and may cause death. That's your definition of anaphylaxis. Right, so it is characterized by, look at this table over here, sudden onset, like I said, rapid progression of symptoms. Airway, breathing, circulation is a problem. There will be skin and mucosal changes, as we saw the picture above of a man who was turning red, with flushing, urticaria, angioedemas. The diagnosis is supported if the patient has been exposed to an allergen known to affect them, but know one thing, that the mucosal changes can be absent in 10 to 20% of the reaction. So if there are no mucosal changes, it does not mean that the patient does not have anaphylaxis. Anaphylaxis, as we know, it should be serious systemic, causing problem in airway, breathing and circulation. So remember that, don't just look at the skin changes, right? Some patients may have sudden bronchospasm, they can have hypotension, so rule out the possibility of anaphylaxis, right? Next, who are the common culprits? Who are these buggers? Who are these bad people who are causing this overdrive? Let's look at them. Let's start with the things that we eat first. Well, common triggers are peanuts. Well, nut cases. Remember, all the nut cases, they're going to cause this disease. Peanuts, tree nuts. Besides that, you can have cow's milk, right? That can cause anaphylaxis. And the other includes, look at this, they can also cause fatal anaphylaxis. Peanuts, tree nuts, and cow's milk, especially in children. The other drugs, you have antibiotics like coamoxiclav, ticoplanin, also goes by the name Targocid, coamoxiclav 23% of the times, neuromuscular blocking agents, chlorhexidine, right, cephalosporins, penicillin, radiocontrasting agents, NSAIDs, all of them can cause severe to fatal anaphylaxis. Okay, and our favorite, little bee, the insect stings. Remember that Johnny Depp dialogue? My dog stepped on a bee. Yeah, imagine going on the poor dog going into anaphylaxis, right? So that's what's happening over here, right? So a picture to just help you remember. There's a bee, dog stepping on the bee, but this time it's not the dog, it's the person who's stepping on the bee. You have milk, cow's milk, crabs, oysters, peanuts, tree nuts, medications, NSAIDs, antibiotics, ticoplanins, coamoxiclavs, neuromuscular blocking agents, chlorhexidines. Remember all that, they're all going to cause. Well, let's brush through the pathophysiology quickly. What happens is, now there are complex mechanisms for pathophysiology, but I would want you to go through them because this is not a lecture on pathophysiology. There are two, for your knowledge. There can be an immunologic pathophysiological response, there can be a non-immunologic response. Let's look at this in a simpler way for our knowledge. Patient gets exposed to an allergen. Allergen can be a food, drug or chemical. IgE mediated, release of IgE mediated can cause activation of these mast cells. Now these buggers, what do? They will cause release of all these histamine, tryptase, leukotrienes, thromboxins, cytokines, prostaglandins. Now this will enter into the blood circulation, will go to various other organs, will cause bronchospasm in the lungs, they will cause coronary vasoconstrictions in the heart, confusional state, drowsy, they can affect the kidneys, they can affect the GI system, right? So that's the pathophysiology. Now, if you look at the previous guidelines, what has changed is in the current guidelines that was established in 2021, now they have put a great emphasis on use of intramuscular adrenaline. Previously there was use of antihistaminics, there was use of chlorpheniramine, there was use of hydrocortisone. Now that has all been brushed aside. They said, go to hell all of you, we just need one guy, we just need adrenaline. He is our general, he is our major, he is our soldier, he is our champion. Adrenaline, 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 adrenaline. That's the emphasis. They said intramuscular adrenaline, and they said repeat it after 5 minutes. If the patient is having, that is, you give adrenaline to the patient if you are suspecting anaphylactic shock. Patient does not respond. How do you check for response? Check for his airway breathing circulation. It is your Bible, ladies and gentlemen. Airway breathing circulation, A, B, C, D, E. Airway breathing circulation, disability, exposure. Every single emergency that you see, you need to manage these 5 things, right? And then your patient will get automatically better. So give the adrenaline to the patient, check for the response. If there is no improvement in airway breathing or circulation, repeat a dosage of adrenaline after 5 minutes. Next, what they did is, this was not there previously. Previously they had dosage of adrenaline for anyone above 6 months. In the current guideline, they ensured that they include a new guideline where the dosage of adrenaline was specified for children below 6 months of age, which was not there before. Next, they put in something called as importance of posture. They said, you're having an anaphylactic, don't move here and there, don't stand up, don't do, don't get into nonsense positions. What do? Lie down supine, right? Or in a position, a semi-reclined position where breathing will be easier for you. That was the third thing they said. Fourth thing, they included something called as refractive anaphylaxis. Now what is this refractory anaphylaxis? Refractive anaphylaxis means basically patient not responding to adrenaline. Despite giving adrenaline, giving IV fluids, patient is going into a circulatory collapse. They included a new pathway or guidelines to how to manage refractive anaphylaxis, which was not there previously. Next, use of antihistamine, corticosteroids, no longer part of emergency line of care. So what are the important things in the new guidelines? Adrenaline, adrenaline, adrenaline. Second thing, they said that for 6 months below, we will tell you what the dosage of adrenaline is. Next thing they said, if you're having a shock, don't do anything, man, don't panic, just lie down straight or sit in a semi-reclined position where breathing will be easier for you. Fourth thing they said is, now they introduced something called as refractive anaphylaxis, which is basically anaphylaxis not responding to your adrenaline and your the other treatment guidelines as per the suggested protocols to us. Then they said that use of this antihistaminics and gimmicks like corticosteroids and all, enough of this, we are not going to advise you to use them anymore. That was the thing. Now this is a beautiful picture that basically tells you where to push your adrenaline. This is an adrenaline injector, right? This is given into the anterolateral aspect, middle third of the thigh, intramuscularly, right? So remember this picture, you know how to give it. Diagnosis. Man, how do you know whether it is patient is having an anaphylactic shock? Somebody will ask us, doctor, how do I know if this patient really has anaphylaxis? Do you have evidence? Of course I do have evidence. I don't talk without evidence. So this is the evidence. Now measure something called as serum tryptase level. Now this is a VVIP guy. You measure him, he's going to be there in the blood. Measure serum tryptase level, but the problem with this guy is it's quite usually normal. After 30 minutes he starts rising, and it reaches a peak within 1 to 2 hours and comes back to normal within 6 to 8 hours. So he goes into his hyper mode within 1 to 2 hours, starts going into hyper mode after 30 minutes. He's at his peak in 1 to 2 hours, and then he comes back to his normal state within 6 to 2 hours. So remember the serum tryptase, this is a question, they're going to test you for this, they're going to ask you for this, and they will ask you. So you be ready and you answer them and you tell them that I know it is serum tryptase levels, right? Next, line of management and all the guidelines. So let's look at the line of management and all the guidelines. The first guideline, anaphylaxis. Like I said, our Bible, A, B, C, D, E, manage airway, breathing, circulation, disability and exposure. Look for sudden onset, deterioration in airway or breathing pattern, patient is going into bronchospasm. Look for mucosal changes. Call for help. If you know there's a trigger, let's say there is a bee stuck to the patient or a bee sting, remove the triggering agent, right? Next thing what you do is put the patient in a flat position, right? Legs elevated with or without elevation, or semi-reclined position, not in standing position. If the patient is pregnant, lie the patient towards the left side, right? Look at this. This is the position and this is where the adrenaline injection is being given. Give adrenaline injection. If airway is not secure, establish airway, give high flow oxygen to this patient because you need to maintain hypoxia. Do not let your patient go into hypoxia. Apply a pulse oximeter, get a 12 lead ECG, check for the blood pressure. If there is no response after 5 minutes, repeat the dose of adrenaline. And this time you give IV fluid bolus. If nothing is happening despite 2 doses of intramuscular adrenaline, you need to change to the refractive anaphylaxis algorithm. Right? Now we'll come back to the dosages and everything. Okay, now before that, let's see. Let's look at the dosage. Now, if you are giving adrenaline, start with 0.15 ml or 100 to 150 microgram if it is less than 6 months. 6 months to 6 years, 150 microgram. 6 to 12, 300 microgram, 500. Pretty simple. 0.15 ml, 0.15 ml, 0.3 ml, 0.5 ml. How much of adrenaline? 1:1000. This is another question. Remember this. Okay. And the airway problems can be hoarseness of voice and stridor. Breathing can be increased work of breathing, wheezing. Saturation levels will be dropping. Patient can go into hypotension. Right. This is one. Next we'll look at the refractive anaphylaxis guidelines. Now refractive anaphylaxis, as I've told you, is basically somebody who is not responding to 2 doses of adrenaline. Now what do you do in this? Establish an IV line, IV or an IO axis. Give fluid bolus. How much of fluid bolus? If it is an adult, you can give 500 to 1000 ml in each bolus. If it is a child, 10 ml per kg is your calculation. Next, what do? You have given adrenaline. What do I do? It's not working out. You can give IV bolus of adrenaline. Although it is not recommended unless you are a specialist, you are a critical care consultant, you are an anesthetist who knows exactly how much dose is being delivered. Do not give IV, do not give IV, do not give IV. Okay. Next is, if you have an expert, you can start adrenaline infusion. Okay, how much of infusion, we will look at it in just a little while. Okay. Look at the dosage. 1 mg of 1:1000 adrenaline in 100 ml, 0.9% sodium chloride. You can connect it via infusion pump. This is the dosage for IV. Start at 0.5 to 1 ml per kg per hour and titrate according to the BP. Next, you need to manage the airway, breathing and circulation. How will we do that? If a patient has stridor, he is probably having an upper airway obstruction. In such case, nebulize that patient with adrenaline, our champion, adrenaline. How much of adrenaline? Give him 5 ml of adrenaline, 1 mg per ml. If there is a total airway obstruction, we need to follow difficult airway algorithm where intubations, emergency tracheostomies, all these things can be done for the patient. Next, for the breathing, if your patient is apneic, go for bag mask ventilation and intubate the patient. If your patient is having a severe bronchospasm, nebulize the patient with salbutamol or ipratropium bromide. If you can get an IV access, you can give IV aminophylline. Inhalation anesthetics SOS, don't go too much into that. At your level, it is important that you know that for bronchospasm, nebulize the patient with salbutamol, ipratropium, and if you have an IV access, give aminophylline. Circulation, circulation, how do I do that? Give boluses, man, 500 to 1 liter of bolus. In children, give a bolus 10 ml per kg bolus, and consider add-on as vasopressors like vasopressin or non-adrenaline if your patient is not responding to an ADR. Establish a central venous access, put in an arterial line to monitor blood pressure in a much better way. And these are all things that can be done in the intensive care unit. Right? The other thing, something an extra edge is patients who are on beta blockers use glucagon. Some of you will ask why glucagon. Reason, it increases your cardiac contractility, heart rate and your AV conduction. Right? Look at this box over here. Sometimes it may happen that your patient is not responding to adrenaline. Now you should know why that can happen. It will happen when you have conditions that are mimic an anaphylaxis. What can be those conditions? Angioedemas which are caused by these buggers, ACE inhibitors, or an increased laryngeal obstruction. So these two conditions can mimic anaphylaxis, in which case your patient will not respond to adrenaline. Now, coming back, why adrenaline? Why am I stressing on adrenaline? Why am I favoring adrenaline? Look at this guy, what is it? He's a beautiful guy, look at this, what is he doing? He has alpha receptor, he has three actions, alpha receptor agonist, beta receptor and beta 2. Alpha beta, how can you forget that? Alpha receptor, beta receptor and add beta 2 adrenergic. So through its alpha receptor action, it will cause reversal of peripheral vasodilation, thereby reducing tissue edema. Its beta receptor action, it will dilate your airways. You remember you're going into spasm, so it will dilate it, will make it easier for you to breathe. It will improve your myocardial contractility, so your blood pressure will improve, hypotension will not persist. And it will also suppress histamine and leukotrienes, ensuring that you're not turning red. And its beta 2 action, it will ensure that all these mast cells that are being released, those culprits, remember, in response to IgE, it will ensure that mast cells are inhibited, they are not released. The next question arises, why intramuscular? Well boss, it is safer to administer, man. Anyone can do it if you have some practice. It does not require an IV access and you're pushing IV. You don't even know what's happening. You can send your patient into a tachyarrhythmia. You can cause hypotension. For hell, you can cause a myocardial infarction and your patient can die on the table. So that's why intramuscular. Location, I have told you already. Anterolateral aspect, middle third of the thigh is the way to go about it. It's an important question. Remember, do not forget. And why anterolateral aspect? I have the answer to every why for you. Because there is rapid absorption and better distribution. That's why we are giving in the anterolateral aspect of thigh. Now, we are done with all this. Now, the other question arises is, when do I discharge my patient? How do I do? Is there a criteria? Of course there is a criteria. What's the criteria? Well, let's say you gave adrenaline to your patient. Your patient has responded. He has got better, right? You didn't have to repeat another shot of adrenaline. His symptoms have resolved completely. There is no previous history of any biphasic reactions occurring. You can discharge the patient within 2 hours. Fast track discharge. Next thing that can happen is, you have had to administer 2 doses of adrenaline to him, right? He has had a history where after going back home, he had another episode of anaphylaxis. Anaphylactic reaction has not resolved. Keep them for 6 hours and observe them. Next, you have had to administer 2 doses of adrenaline. Patient has had history of biphasic reaction in the past. Patient is an asthmatic. He has come to you late at night where access to hospital or emergency is not easy for him from the area that he is coming from. Then what do? You keep him for 12 hours at least for observation, where you can teach him how to use a adrenaline auto injector and you can send him back home after 12 hours. Simple. Let's look at the questions, right? Before I bore you all to death. So let's look at the questions. These are the type of questions that you can get. This is from Anki again. They can ask you sudden onset and rapid progression of anaphylaxis, blah blah blah, following things can happen. Hypertension, wheeze, swelling, widespread erythematous rash and pruritus. This is one that thing that can come. It can ask you about adrenaline, that the dilution, like I said, anaphylaxis 1:1000, cardiac arrest 1:1000 IV or 1 ml of 1:1000. This is the dosage according to our ACLS guidelines, right? Next, how often do we have to repeat adrenaline? Every 5 minutes. I have told you the route of administration, intramuscular. The other thing is about our about our tryptase levels and the discharge process. How long the patient should be observed in the emergency department. I told you when you have to observe them for 2 hours, 6 hours and 12 hours. Just follow that. An important note on tryptase. Of course, this has changed. Now it's 6 to 8 hours, not 12 hours. The questions on Anki is as compared to the previous past medicine update. So just remember that it is not 12 hours. It is around 6 to 8 hours for which your tryptase levels remain elevated. So yeah, congratulations, we have saved our person, right? He has gone back home, he's quite happy, he said you're a wonderful doctor. Well, so that's going to do it guys for today. If you think you got something out of today's video, then please do like, share, subscribe to our videos so you don't miss out on our regular updates. Until next time, keep reading, keep revising. MRCP made super easy. We'll see you again with another video on another day with as much energy and enthusiasm as always. Take care, bye bye.